Hi, everyone. My name is Cherie Santos, and I'm a nurse with ALS United, Greater New York. And I am glad that you're joining us today. I want to introduce Katie DeMarco, who is a palliative APN at the Hackensack University Medical Center's Pain and Palliative Medicine Institute. She is an instrumental part of the Hackensack Meridian ALS clinic team. She is a dream medical provider and elevates the practice by seeing the whole person, not just their ability or disability. Thank you for being a part of this today, Katie. We really appreciate it. Everyone can please put your questions in the Q&A, and Katie can start her slideshow whenever you're ready.
Okay, great. Well, thank you so much for having me, and great to be working with Charisse on a frequent basis in our ALS clinic at Hackensack. I'm going to go ahead and share my screen and let me know if you have any challenges with viewing it. Okay. All right. Well, again, I welcome you to this session where we're going to be talking about understanding palliative care and really how we create purposeful connections with you, the person with ALS or the condition, or family members and caregivers. And I hope to be as comprehensive as possible so then we can connect the dots about how palliative care can be really, really special for you. My disclosure is that I really have nothing to disclose other than I am passionate about palliative care. I have no financial or commercial concepts that I'm affiliated with. So really just one of those clinicians that works day to day with patients and loved ones. We're going to talk about personhood, lifestyle, and how we adapt as people with illness or family and caregivers, and how palliative care can really serve and value all of your strengths and all that you're already doing, as well as give you different care plans, resources, and suggestions on how to optimize quality of life. So from a show of, say, in the chat or electronic hands, I wonder, what is palliative care to you? Have you heard about palliative care? Maybe yes, maybe no, but it's always nice to know what our spectrum of worry and wonder and knowledge is. So I wanted to offer that as an opportunity, and maybe Charisse and others can give me some feedback as we go along. Palliative care is for people who have a serious or even a life-threatening illness. We are specialists, such as myself, being a nurse practitioner, focusing in on symptom management, offering the resource of advanced care planning discussions, and really focusing in on quality of life about what matters most to the person's day-to-day and what are their lifestyle preferences. We incorporate these concepts with the caregivers and families in mind as well. We're very person and patient focused. So going back to symptom management just for a moment, we look at physical symptoms and burdens. We reflect on emotional experiences and perhaps challenges or growth opportunities, as well as spiritual and other concepts that might resonate with you. Most often, palliative care is a team of people. And I'm fortunate at Hackensack that I have an interprofessional team of chaplains, social workers, psychotherapists, physicians, nurse practitioners, nurses, and other healthcare professionals that I work with on a day-to-day basis in the hospital setting, in the nursing home setting, and then, of course, working with the ALS clinic, working with the ALS specialists of all different licenses and disciplines. So we are natural collaborators, and that's what we will also do with you, a mind, body, spirit focus, and working with the team that you desire to work with in a medical way. Palliative care recognizes that every path, every process, every patient is different. We acknowledge the human part of having a good day or bad day with your diagnosis added on. We acknowledge that sometimes within the same moment, you can have discordant, contradictory feelings and experiences. And we want to hear about those things if you want to share. So ultimately, palliative care is about people. Palliative care is about how best to take care of those people in a meaningful manner and to purposely connect the person and the medical circumstances together. So that's where clinical personhood is intertwined and connected in almost like a puzzle piece. You're not a patient when you have a diagnosis. You know, in our healthcare system, in our society, we kind of bestow or cloak you as a patient, but you're really yourself with new added information, new added experiences. And so that's why we really like to uphold the person and the clinical part coming together. And how do they affect each other? And so at the time of diagnosis, at times when stress could be high, when our ALS changes or our illness changes, even when we're nearing end of life, what matters most, or what matters to me, the person who's going through this, or the caregiver that's going through this, that's a very reflective and almost ritualistic statement or phrase that I highly recommend, whether it's internal reflection or communicating about this reflection. Palliative care, we have 8 domains that are really highly specialized on getting to know the layers of you and the medical clinical circumstances of what is occurring. Yesterday, when I was preparing for this presentation and discussion, there was a question that was proposed about how do I gain access to palliative care? And is it covered by insurance? So domain 1 happens to be all about structure and processes. So it's a really thoughtful question about how do we get access to specialty level palliative care? Where is it located? And is it easy to gain access, or are there barriers and challenges? In our New Jersey and New York City area, we actually have a very robust palliative care system that is diversified at locations like Robert Wood Johnson, Hackensack, Valley, Columbia, Mount Sinai. I could go on with the list of hospitals that have access to palliative care. And they're all great programs to lean on. But a lot of times people want to reside outside of the hospital, or they're only temporarily in a hospital. So there are palliative care clinics that are available in the outpatient setting, or even with telehealth through the computer or a smartphone, of course. And there are home-based programs as well. We're fortunate in New Jersey that home-based programs are available in the northern area and the southern area. There ends up being some challenges within that New Brunswick central area, but we can talk more details if and when it's helpful. Ultimately, palliative care is a benefit that is covered by insurance. And New Jersey values palliative care so much that, in fact, we just passed a law this past year that now palliative care is going to be covered under Medicaid and even Medicaid home services for people who are working with New Jersey Medicaid. So there it is covered, and there's a lot more details we could review at a different time, but did want to formalize that answer to the question. Want to take a pause in case Charisse or any of the moderators have feedback for me regarding additional questions or even the ponder of what is palliative care.
Katie, I do have a couple questions, but I don't know if you want to go through them after. You did say about hospitals having palliative care, but do all of the ALS clinics or centers at hospitals have access to palliative care?
Great question, and it really does feed into my next slide, that neuropalliative care, where we're embedding palliative care into neurologic services, is really up and coming and has been for probably the past 8 years or so. But what I've been observing in the past 2 years is a lot of momentum to integrate palliative care automatically. At Hackensack ALS Clinic, we're fortunate that palliative care, which is myself, joined Charisse in the ALS clinic as a standard of practice. Palliative care sees every patient and companions them and treats them just like the speech therapist, just like the neurologist and the other specialty clinicians that are part of ALS clinics. But we are a unique model that standardizes and automates this type of collaboration. Other ALS clinics have access to palliative care, but it's more so a consultative model, which means requesting palliative care, possibly a separate appointment or inviting the palliative care team to come to the ALS clinic intermittently. And I recommend highly that, whether in this moment you think palliative care could help you, or after this presentation and learning session, if you think that it could help you, let your ALS clinic know it's meaningful for you to explore. Let them know that there's a particular priority of having that collaboration, as there are ALS clinics that do not have access to palliative care. So we'd like to elevate the awareness that palliative care could and should be a standard of practice everywhere, but we're not quite there yet. If you have any questions about that or need help with gaining access to palliative care, at the end of the presentation, I'll have my email and would be happy to continue to be a resource through the ALS team. And Charisse can, of course, let me know that as well. So when you're working with palliative care, what you might expect is us to get to know you in whatever way serves you. And oftentimes I will ask, tell me about you, or what's your story and your experience? Some of the social aspects of care, what makes you you, is all about, your, how do you identify and define yourself? What stage of life are you in? What life experiences do you have? How comfortable do you feel with healthcare navigation, or how functionally are you with, getting yourself dressed or adapting to all that's happening? We look at the social aspects of care and getting to know you as not only the most important foundational concept, but something that's really intimate, something that's really special to learn and get to know you and your family, whether it's chosen family or your support system, or the biologic structure of your family tree, your living arrangements, and even identifying and talking out what makes you feel safe within your relationships, what makes you feel connected, what intimacy or even concepts of sexuality is important to you, and open to have that discussion. In addition, those financial resources, burdens, even financial toxicities are really important, that you have an open door and platform to talk out these concerns and anything that is important in that moment, or know you can talk about it in your future. Palliative care really opens the opportunity to get to know you in an additional layer of cultural aspects. And these are really just thought bubbles of what you might think on with sharing with your palliative care team and ALS clinic team about your religion, about your race, and what is important to you. All of these things could be said in one moment to a next. You could be vacillating to all of these different concepts. But again, this is an invitation to be yourself rather than just the patient that you feel you need to be in that moment during an appointment or in a healthcare system. I also highly recommend that we consistently focus in on preferred communication. Think about primary or preferred language. We often use technology devices or communication boards or boogie boards to communicate. Also talking about what words don't feel comfortable to hear or say, and perhaps what language honors you with clarity and consistently of what makes sense, but also honoring boundaries if we can follow them in that cultural or personalized manner. It can be helpful and meaningful that we also review what customs, beliefs, traditions are important when you're actively living, when you're actively considering what legacy or meaning making is important to you, or while you're nearing end of life. Even after one has died, what rituals or concepts are important for the family's reflective bereavement or next steps. Spirituality and religion could be an important part of who you are. I don't like to assume within my palliative framework, and so I and other palliative care clinicians will explore. Do you have a faith-based religious framework that is meaningful to you? Or perhaps are you thinking on your spiritual framework? Are you connected to nature? Or is there that more formalized religion or community that guides you through life as well as with your illness? These are prompts and questions that, again, we don't assume, but we unpack. And oftentimes people have that inner feeling of why, and that existential inner angst of why is this happening to me, and that feeling of what is my future, and kind of sitting and living in uncertainty can be one of the most uncomfortable concepts that my patients share with me. And so you are not alone if you've wondered about this. And this is the time where I want to bring up how palliative care in a telehealth or in a bedside visit or in your home can absolutely unpack this spiritual or existential wonder. You know, this is the time where I remind you that as we get to know you and as we get to know the clinical medical situation, we put those puzzle pieces together and we reflect on what matters most. There's been times where I have become a scribe in legacy making and writing letters to loved ones that the patient wants to leave behind. Or there's been times where we've been able to partner with different organizations to do a video biography. There's been times where we've just wondered about, why is this happening? Because we got our genetic testing and we don't have the answer of why do I have this diagnosis? So these are active palliative care appointments and interactions that are absolutely available to you and to your loved ones. Another part of getting to know someone is their mind, is that psychological or psychiatric aspect of themselves and the care. This scribble spot on the right-hand side, I love him because this little icon is feeling and thinking so much, and all of the thoughts are coming together, and it's really affirming that we can have different feelings and emotions experienced at the same time or within the same day, and absolutely within the same lifetime. The most common emotional experiences or symptoms that my patients share with me is the angst of stress. Everyone's stress level just goes on high alert and penetrates into their being, and it almost ends up being contagious. And I say that in a serious manner, and also in with a little bit of humor, because you can feel it, you can palpate it, and it's something that that can be really vulnerable and really sacred to talk over the stress that might cause racing thoughts, or the worry and the anxiety of what you're going through, the angst and the sadness. Sometimes people even feel like they're angered, frustrated, and that, they don't have patience when they're driving, or they don't have patience when they're, seeking help, when someone's helping them to get changed. We also acknowledge that people can get a little scutchy or agitated. Behavior changes could happen because of stress, or even because of cognitive impairment, or the brain changing, and confusion. So my patients have leaned on me to talk these things out, to prescribe medicines if relevant, to consider alternative modalities like Reiki or aromatherapy and other things that can ease their emotional experiences and symptoms. But again, connecting what matters most in that moment is really, really important, because today's what matters most could be very different than, say, 3 months from now. Another opportunity that I briefly mentioned in that social aspects, but I wanted to bring forward, is that palliative care can absolutely be helpful and important in reviewing themes of intimacy, connectedness with yourself or others, even exploring pleasure with yourself and your partner, that personhood concept of sexuality. And it's a human concept to want to feel connected to people. At different times of our life, at different moments during our day, sometimes feeling connected is literally sitting by someone and just feeling their presence and energy. Other times it's snuggling and hugging, or having a deep conversation about what they enjoyed in the day, or what they're preparing for regarding their illness. Sometimes it is palliative care and the person or the family talking about relationship modifications, how day-to-day roles in fact do change, and how do we become resilient with flexibility? How do we redefine our roles and still feel like we're contributing to ourselves, to what matters most. And then also mentioned that telehealths or appointments that focus in on that pleasure and sexuality of being a human is absolutely something that palliative care can do, whether we're prescribing medicine or talking out safe practices about how to have pleasure and different sexual positions. That may feel vulnerable, or that may connect with you of, yeah, I want a safe forum to talk that through. Physical aspects of care is something that's really important, because if we're not physically safe, if we're physically uncomfortable, or there's a particular symptom or even many symptoms that go awry, it almost feels like we have more barriers to get through our day. And so palliative care are symptom management experts and really want to personalize your treatment and symptom management experience. We oftentimes will work with medications to help you with these symptom burdens. And we also will talk through and educate you which medicines could help versus which resources or non-medical concepts could help your symptoms. The most common physical symptoms that my patients talk to me about are muscle spasms, or that spasticity and stiffness of their arms or legs. Perhaps even a drooping head or neck can be a challenge. Some secretions or drooling can absolutely be something that is difficult. And intermittent constipation, if someone's having less oral intake, or if they're having less intake through their PEG tube, if they're less mobile, then constipation can be a periodic or a worsening symptom that someone's feeling. Difficulty sleeping is a high common symptom burden, whether they're having difficulty falling asleep or staying asleep, or even if they're starting to have active dreams because they're processing something that they're thinking on. Those are all concepts that we can talk out and even sometimes prescribe medicine that can really, really relieve this adjustment insomnia or other difficulty sleeping concepts. Patients are often fearful and worry about the concept of shortness of breath. We call it dyspnea in that medical framework, where someone's having the sensation that they can't get their breath eased or calm, or that when they exert themselves physically, they get worked up by not being able to control their breathing at a normal pattern. This is something that we can absolutely help support through fans, through nebulizer medical treatments, even sometimes going on that home ventilator temporarily, or just sitting and resting and relaxing with a calm app and a meditation app. There's all sorts of ways that we can mediate these physical symptoms. And cough is sometimes a cluster symptom connected to drooling, connected to shortness of breath, or sometimes we just have springtime allergies because it's May and we might have a postnasal drip that causes a cough, and simply treat that to ease and help the cough. In the past 2 weeks, I'll share with you that I've done telehealth drooling appointments. I've done an oral mouse appointment focusing in on facial muscle spasms, where someone by accident bit their mouth and now they have a little bit of an ulceration and sore and localized infection. I've done recently an appointment about urinary urgency and ruling out a urinary tract infection, and working with the patient's primary care physician to make sure that that the person does not have an infection in their bladder. So again, physical symptoms, I almost consider that a way that your body's talking to you. If you're feeling something and if it's uncomfortable, then perhaps your body is telling you it's important to talk about it and seek help so you can have a better day. Before we move on to the care decisions and documents part of our discussion, I wonder if there are any questions or comments that we should focus in on about those physical symptoms, the emotional, psychological, or even social and cultural perspectives.
Yes, there are several questions in the chat coming in, and we'll address some of those at the very end. But
Okay.
regarding the physical symptoms that you're talking about, someone asked, is sweating a common symptom? And then the next question is, does palliative care include simple counseling?
Great questions. So when I find that someone is sweating, I often find that that might be related to medication side effects. And it also could be related if, in fact, they're in a particular bed or chair in a prolonged fashion. It would be something to definitely unpack and assess further, for you specifically to understand when it might be happening or what other medical illnesses and diagnoses might you have or not have. But I haven't necessarily found sweating to be interconnected routinely with the diagnosis or the illness of ALS. And that's just from my experience working with patients and clinically for the past 4 years. So I offer that as a suggestion and guidance, but it might be something relevant to talk out with your neurologist or your palliative care clinician, as there are treatments for overactive sweating, particularly if it's bothersome to you. So it is a relevant symptom to talk about. The other question, Shrees, I apologize, it blipped out of my head, the second question that you had mentioned.
Does palliative care include counseling?
Okay. So palliative care can include counseling, psychotherapy, and things of that nature. In my palliative care program, we do have palliative psychotherapists that provide that type of counseling and processing. It's not readily available in every single palliative care program. So as an alternative, one of the suggestions is working with a counselor or psychotherapist that is familiar with motor neuron disorders like ALS. And if you find that you're having difficulty getting a good link to someone who has that background, then Sharice and the ALS Greater New York can absolutely give some feedback because they do have some resources and guidance that could help. So it depends upon the program. All right, so moving right along to care decisions and documents that can help support you with advanced care planning. There are several different care decisions that you may be making, and you might not think about them in this bulleted fashion, but I wanted to bring them forward to give space and presence and really honor all that you are thinking through. When you're diagnosed with ALS or a motor neuron disorder, you are thinking about, what's my care plan? You're thinking about, am I going to work with medicines or not? Am I going to join an ALS clinic or not? You're going to be thinking about things like, do I want nutritional supplements at some point? Do I have interest in a medical feeding tube in my abdomen? At some point, you may even discuss with your clinical team about your airway, about your breathing status, about if your heart should stop and that resuscitation or code status. You're going to be experiencing at different times what care decisions you're thinking on, what questions you may have about these types of concepts. And at some point, you may feel confident about, yes, I do want these types of decisions and care, or no, I don't want a tracheostomy. No, I don't want a ventilator. And there might be a lot of things that you want to opt in and say yes to. Your ALS clinic, your palliative care team, again, we don't want to assume what types of medical interventions are you going to do or not to do. We don't have an agenda of what you have to do. What we want to offer is support and education and talking through your medical preferences, connecting your values and what is important. And there are some documents that when you feel confident could be really helpful to complete, to talk to all of the doctors and nurses, and to keep your chosen family or biologic family informed about your decisions. Again, every path, your journey is unique. Sometimes family meetings with your team, that support team and that medical team can be really, really supportive, because that's a safe area where you can ask your questions. Everyone hears the same concepts, and you can have more thinking, reflecting time. Other times, your care decisions, you may need more support in making an actionary decision about that feeding tube or about a communication device that you're considering. And again, a family meeting, whether it's telehealth or getting together physically or joining you in your home, could be really, really meaningful for you and your loved ones. An advance directive is a type of document that you might want to consider. If you have someone that you trust and that you would like to designate as your healthcare representative, an advance directive is a really, really great document to share with your nurses, doctors, and clinical team. It means that if you went through a medical emergency, or if for some reason you weren't able to communicate to your family, to your clinical team members, that this paperwork would say exactly who to call and help make your medical decisions. And so that's the number one. I'm just going to put my cursor over here. The person I want to make care decisions for me when I can't. There are all sorts of advance directives. 5 Wishes is an example of it, and you can absolutely Google, or we can pass along a PDF. New Jersey and other states have their own state forms, which can be really supportive. And these documents can be completed in the ALS clinics that you participate in, or in the clinical offices that you participate in. Palliative care can assist you, of course. There is no cost, as there needs to be 2 witnesses to complete this, or you're welcome to use a notary republic if you prefer. But an advance directive is a really great medical legal document to identify the healthcare proxy. In addition, you can add even more information about your desires, wishes, and medical preferences, but that might be supported best with a conversation together with palliative care or a clinician that you trust. Sometimes we go even the next step further. POST, which New Jersey has practitioner orders for life-sustaining treatment. This is literally a green state form that turns your wishes into orders. And so that's really different than what we just reviewed before. So let me go back. An advance directive is information and gives us direction about your medical preferences and wishes. And we work with someone, most commonly about, whoever you designate, we work with that person to make your plan actionable. But orders through the post form have to medically and legally be honored. And so you, the patient, or if the person who's sick can't participate, the decision maker works with palliative care or the ALS clinic or someone who is a physician, APN, or PA to complete all of these different sections. And we recommend post if you have a serious or life-threatening illness and you are confident about what you absolutely do or don't want. One of the great things about this post form is that it offers continuity. Every area in our state of New Jersey has to medically and legally follow this form. So that means that the emergency EMS, EMTs, 911 have to follow this form. Every hospital that you enter with this form at hand, they have to follow this form and these orders. So does your ALS clinic and anyone else taking care of you. That includes subacute rehabs and nursing homes. So this form is quite powerful with turning your voice and your wishes into orders and sharing it with any of the team members that you're working with in a healthcare system. So this is something that we offer within palliative care, but again, any doctor, nurse practitioner, or physician assistant can actually fill this out. And if you're from the New York or the Pennsylvania or alternative, state, they do have, most states do have a post or a most form, which emulates and copies this process that is specific to their state. As people's bodies change, as someone's illness becomes more progressive, we ready for when we near end of life or when we're actually within that dying time. Support and education about end of life care is something that palliative care is very skilled at, as we uphold the spectrum of life and also identify that dying, whether we're dying from ALS or complications of something else, it is part of that human life cycle. It is vulnerable, though. It is one of those things that all humans wonder about and sometimes have fears or worries, going back to that existential part that we already talked about. And so palliative care can be a resource to talk about, signs and symptoms of dying, or reinforcing how can we help you be very comfortable on your day-to-day. How can we help support and coordinate end-of-life care wherever you reside, through hospice services, or through a residential location like a facility, and also talk through your medical values, your personal desires about medical donation or research-based donation and things of that nature. Palliative care, as you have seen, is living with illness and focusing in on quality of life. And it's paid for by insurance, and we kind of wiggle and waggle in any direction that you need help with. We focus on what matters most to you in this moment. How do we help support your anticipatory needs in all of those layers that we talked about before? Where hospice is a very specific end-of-life service, it's also part of an insurance benefit, But we talk about hospice and we start hospice when we're more so in 6 months or less in estimation to life. And within this vulnerable and very sacred time, you, the patient, and decision makers get to decide which clinician, which physician or nurse practitioner or PA will become your hospice attending and join you in this journey of specialized end-of-life care. Palliative care is often that team member, but you get the decision to ask anyone that you're working with as a physician, nurse practitioner, or PA to join you in that journey. Overall, palliative care can absolutely be considered to join your support team at the point of your diagnosis. You can lean on palliative care in any one of those domains that we talked about today, and you may even have more ideas about what you want to talk about. You may want to share different things than what I illuminated today. And I suggest that you carry with you the reflection of what matters most. You can share it with your present ALS clinic. You can share your thoughts with your family, with your support team, and please absolutely share it with your palliative care team if you have one that you want to work with. And this is just a brief visual summary of some of the pearls and points that we went over today, but I thought it was a really great, almost pocket guide of reinforcing what we talked about. I hope that this gave you an overall sense on how palliative care helps with purposely connecting, getting to know you as a person, getting to know your medical and illness circumstances, connecting the dots, and companioning and journeying with you on all the good parts and the bumps of your journey, and really just being present to see how best to help you within your next step, this moment and your future. I open it up to Charisse, and you all give me guidance about how I can help next and what questions might be needing to be answered.
Thank you, Katie. That was amazing. Really appreciate it.
Absolutely.
I'm going to go back to the top of the questions. You mentioned that in New Jersey about the Medicaid covering, but do you know if New York Medicaid covers?
New York Medicaid covers palliative care services, but I don't believe that they cover home palliative care under Medicaid yet. So that would, an appointment or a telehealth or in the clinic would be covered. I believe that they are strategizing on the New York home-based palliative care, but it's not up and running yet to my knowledge.
Okay, thank you. And then is palliative care covered under regular Medicare?
Yes, absolutely. It is, and that's where you can lean on just, making an appointment if and when you want one and not worry about as many financial concerns of it not being covered. So absolutely covered under traditional Medicare and those programs as well.
Okay, and there's a question here. Do you advise on the new right to die law, which I'm assuming is medical aid in dying in New Jersey?
Mm-hmm. So medical aid in dying in New Jersey became actionable in law in August of 2019. It is something that I talk with about my patients when they're exploring what matters most within their end-of-life care plan. And sometimes we talk about it and it's for support and informational purposes. And sometimes we talk about it in more of a actionable way that they want to go through the process. And so I am a guide through that process. And I have had patients that have implemented New Jersey medical aid in dying. It is something that, any clinic or clinician may be able to discuss with you. It's something that you can Google. However, I recognize that it is a very personal, intimate, and vulnerable conversation. And so it's one that I recommend that you have with someone that you trust and someone that's knowledgeable. And when you find your palliative care program, that might be a question that you want to ask if they are able and willing to speak to you about it. But there are clinicians that have experience in it and have accurate support to offer you.
Thank you. And then why do you think people still confuse palliative with hospice as it's the same entity?
Good question. Hospice care was formalized in our country first. And because of those roots, and because we saw back in the 70s and 80s how powerful hospice could be, it happened to be the nursing field that saw the quality of life that patients were gaining from hospice services. And nurses were the ones to say, I wonder if we can bring hospice-like services to people earlier in their illness. And their born was palliative care. So there's truth that palliative care and hospice are interconnected. We have so many considerations, and I'll even go back to the slide that shows the similarities. I think it's interconnected and confused beyond that because people are afraid to say the H word, meaning hospice. I think it has become more palatable to say palliative care. And ironically, now people are looking at palliative care and even asking me, can you change your name away from palliative care? Because everyone thinks you're hospice and we don't want to, confuse things. In my program at Hackensack, I know that we're not changing our name because we want to be transparent about that full continuum of palliative care. We also want to be transparent about when we transition towards end of life and when we might partner with a hospice organization and agency. Supportive services are sometimes used instead of palliative care, but supportive services includes, nutrition specialists and infusion centers and other kind of modalities and interventions. So I think it is cultural jargon at this point. Yesterday, I just got a consult in the hospital, and there was a person in the emergency department, and the doctor was recommending palliative care. But when I started to do a chart review and get to know them medically, I was realizing that their prognosis was likely less than a month. So I called the surgeon and I said, thank you so much for this consult and referral. Our team's going to go to the bedside and see how best to help. But I'm concerned that we're not talking about hospice. And the surgeon was honest with me. He said, oh, Katie, I thought palliative care was hospice. I'm so sorry. I want hospice to meet the patient too. And then we could just, bridge his knowledge, support him, and get the best resources to the patient. And so we helped in that way. So I wish it was different. I've been doing this for over 15 years, and I will continue doing it to help differentiate and support the differences. But now that you all know the difference, you're almost like those amazing champions and those therapeutic redirectors to say, oh, palliative care is this, and hospice is that. So I'm going to lean on you all by asking you to support your friends, support your family, support your doctors and nurses. If they're mistaken, correct them. It's okay.
Great. And I took a picture of that slide. I like this slide a lot. Let's see. Do you know if Robert Wood Johnson has a palliative program?
Robert Wood Johnson does have a palliative care program in their hospital. They more recently have a palliative oncology program with appointments. I don't know that they've partnered with the ALS clinic yet, but I think that if the ALS clinic and palliative care heard of the request, heard of the need, I think that it's something that they would reflect on and perhaps grow to. So that's why I would encourage you all to be advocates of, if you think that palliative care can help you or your loved one, then go ahead and vocalize it. Know that not every program has palliative care embedded or even consultative just yet. But when programs and health systems hear the need, I do feel more confident that it will come. You know, what is it called? Like if there's a movie, like if you build it, yeah.
If you build it, they will come.
Yeah, and so it's almost like we have to verbalize we need to build it. We know we need the need, so share it so they can build it, and then let's go. Let's do it together.
Great. Let's see. Can you go back to the summary slide, please? Maybe somebody wants to take a screenshot of that.
I wonder if it's this one or the bulleted one.
Let's see. Maybe they'll type another question if it's this one or not. But I guess leave that one up, and then we're going to go to, let's see, another question or comment, actually. I work in an ALS clinic, and this makes me wonder why palliative is not utilized more. So, and that goes back to, if you build it, they will come.
Yeah. Yeah, I remember when I first was talking to our Hackensack chair about the developing ALS clinic. And I was talking to him about why I thought palliative care should be embedded. And we were going back and forth about the consultative approach, the standard embedded approach. And what I, hopefully respectfully said was something to the effect of, let me join the clinic for several months. Let me see how I can help. And let's get feedback from the team, from the patients, from the families about if there's anything that I or palliative care should modify. Let's see if there's anything that tells us to only be consultative. And I feel really fortunate that through this embedding standard process, I've learned a lot. Like I feel like I've learned from Charisse and all of our other clinicians, but ultimately, I think palliative care is an asset, and I've stayed, 100% embedded in the clinic. And I think it's been proven clinic after clinic that we all contribute. And so it's a relevant question to your clinic, when might we embed palliative care into our clinic? How might that start?
Okay, this was the slide that they were referring to. So thanks for putting that back up.
You're welcome.
And I think I went through all the questions.
Okay.
I don't want to miss any. There's a comment that Mount Sinai ALS Clinic has palliative 3 times a month on clinic days. So yeah, we went through all the questions, and I thank you again, Katie, so much.
You're welcome.
And I want to invite everyone to join us for the next session at 12:30 with for drug therapy with Aaron Manning. And join us then. Okay. Thanks, everybody.
Bye-bye. Thank you.